let's start with the beginning. Are we going to do the beam protocol first?
Yes.
Okay.
Beam protocol, yes.
So we get a little cap. We put the cap on him. And just like Bill said, you want to develop a method by which you have the cap on the same way each time. So you want this to be in the center. And when you move it to the center, you can't just move it, because otherwise the rest of the hat will just bring it back. You have to move the whole hat to make sure that that's in the center. Then, see, that's precisely what we want to avoid, having it go all the way back like that. We want this to be like at the eyebrows, no more than a centimeter above the eyebrows. Really, we should measure the distance from here to here, but it's about the same every time. Is this perfectly symmetrical? I don't know. You have to look from the midline. Is it pretty symmetrical now? Okay. So, after you have several years of experience, you'll find out that DLPFC is right there. Let's see how close I am. Who's got a tape measure?
Here we go.
Tape measure. Okay, so we want 3 measurements. The first measurement we want is the tragus to tragus. So this part of the ear right here is the tragus. Okay, so you want to measure from the tragus. Some people measure from the preauricular point, the top of the tragus. You want to kind of go to the other one, okay? And what I'm seeing is 20, 30, 37 centimeters. Now, would it have made a difference if I did it there? Or if I'd done it there? Yes. So you want to start here and go to the inion. And the inion is this little bump. It's like a little hill at the back of the head. And because I'm a little bit obsessive, I wanted to know if you measure to the beginning of the inion, the top of the inion, or the other side of the inion. Exactly. Luckily, all this is available in instructions on how to do the 1020 EEG system. So it's the back. It's the farthest part of the inion. It's the bottom of the hill after you've gone over the inion hill. Does that make sense?
Yep.
And we have, in this young man, we have a measurement of 39. Now, 39 is a lovely number. And half of 39 is 19.5.
So this is basically EEG measurement, right?
Very similar up until now. Okay. So this is half the distance from the Nasian to the inion. And that is where we should do the tragus to tragus measurement. Through that little midpoint. I'll put this, and it's 37. Okay, I did it eyeballed. Truthfully, if it was a centimeter in front or a centimeter back, it won't make a difference. Say what?
You want me to hold it so you can mark it?
No, you're good. You're good. Okay, so 37 and 39. Then we want to find out the circumference. We always do the circumference right at the hat and around the inion, and that's 60. Okay, who has a computer? Oh, it's up here. Okay.
It's up there.
So 37, 39, 60. Now, the one thing you want to make sure is you've got the numbers in the right order. This is really easy to mix them up. So tragus to tragus was 37 centimeters. Does anybody have any questions about these 3 numbers I came up with? Does it make sense? Does it look easy?
Did you go above the ear when you did the circumference?
Yes.
Or you said?
Yes.
Okay.
So 39. Tab, and then 60, and then we hit calculate, and the machine gives us 2 numbers back. We give it 3 numbers, it gives us back 2 numbers, and the 2 numbers are 7 and 10.
I think Monique was just trying to say they have some really great videos online of this.
Yeah, so if you don't want to take video of it right now, we have it, we literally have all videos of it online.
Really nice.
Yeah.
Yeah, so we now have 2 numbers, 7, 10, right? So we start from the center here, and the videos online are probably much better than me doing it. I think anything online would be preferable to this, right? Just kidding. Okay, so what did I say, 7? Yes, there are videos of me online, God forbid. So we mark this at 7, all right? Don't worry, I don't have any germs. Okay, so we got a little marking there, right? So then we take our measurement and we go from here to that mark, but not all the way. That's the trick. Is it's in the direction of that mark. How far do we want to do it? It told us 10 centimeters. So the point 10 centimeters, so I was 1 centimeter off when I guessed.
And that's the LPFC.
So that's the DLPFC. Now, when you put that point there, how confident can you be that that's the DLPFC? Here's what I would recommend you do if you have any doubt. Spend $50,000 on a neuronavigation system. Then do beam protocol every time and use the fMRI guided either the individuals or the MNI average brain and watch what happens. And you'll find that the beam protocol is exactly where the neuronavigation system is going to be. Like there is no variation. It's remarkable. And when you realize that, then you realize that instead of spending $5 for a tape measure, you spent $50,000 on a very complex machine that does something that you don't need to have it do. I'm not saying you shouldn't get a neuronavigation system. There's some very good reasons to get a neuronavigation system, like if you're doing tinnitus. If you're a neurologist, I don't think it's a bad idea to get a neuronavigation system at all. Elahi's got one, he uses it every day. If you're a psychiatrist, the vast majority of what you do is going to be DLPFC on the other side. Do you want to see how to find DLPFC on the other side? Turn this inside out. You think I'm joking? I'm not joking. Oh, we didn't make a big enough mark. Hold on. Got to get sloppy with this mark.
You're messing with my head.
Yeah, I'm about to give you a tattoo if you're not careful. So there's right DLPFC. And you can redo the beam protocol if you want to, or you can just turn it inside out. I usually do it behind the patient so that they don't see me doing that. Because it looks a little bit funny, and this looks very bad. So you can actually get less expensive hats. This is a wonderful machine, and you can buy it from this company, but don't buy their hats. Could you go away for a couple minutes? Nothing. There are other hats you could get. I will send you a link for $4. You can get a better hat than this. You don't want to buy hats from a TMS company. Yeah, you can get Lycra swim caps for $4 instead of, how much are these, 20?
20.
Yeah.
But we really, that's how much we're paying for.
Buy the
And we tell them-
TMS machine from
And we
him.
told- yeah, we
I will
told them
send you a
about
link
that.
for the hats. I can't see spending.
I agree with
Yeah,
you. No,
yeah. So there's a very inexpensive way, and they last very well.
But people keep on saying.
Yeah, you don't have to buy it from them.
No, you really don't.
Or any of the other companies. It's just unnecessary. So, oh, I'm sorry. Let's put that back on so we can show you coil positioning. Yeah, you got this. And you notice that I'm putting it on in the same way that it was on when I marked it. Is that pretty centered?
So this becomes your patient's hat, essentially.
And we write their name right
Write
here.
their name on it.
But you keep it in the office then? You don't give, do you give it?
Usually,
If you have more than one location, you can either make more than one cap for the patients. We used to have 2 locations, and so we would, you know what, I'm going to move you. Can you stand up for a moment? Yeah. There we go. So, yeah, you can give it to the patient to hold on to, but they won't bring it in with them. So we have a little filing system for them. Okay, so now how do we bring this to them? This is another thing that's really good about CloudTMS. So somehow this coil that the CloudTMS people made is really light. And somehow their little arm here, it works really well. Like the other companies, they don't have arms that are as good, they don't have coils that are as light, it's harder to put the thing where it needs to go. So,
What about the cap?
$20
Where do you put
Is it
the-
$20
it's
hat?
in the middle of the year?
usually a little bit above the ear. This hat's too big for them. The other thing we do is, for almost all patients, we cut the elastic here before doing it, because if it's really tight, it can cause headaches. And we don't want to cause headaches. This is just too big. You can't place this. If you place this properly, then look what's happening. See? So, but over the ear is fine. You know, the distance from the place that you're interested in doing to the area that's in the wrong place is so large that it doesn't alter this. Like if you reposition. So, let me get up again. Sorry. I'm just going to turn him around so you can see the point of a seat here. Okay. Okay. So now we know where we want the coil to be tangential. So we want this part of the coil right there in between these two holes, center, to be touching this right here. Now, in some ways, there's an infinite number of different angles it could occur at, but the one we want to have it occur at is, first of all, so that the distance between these two, like if you put your fingers under here, sorry if I'm poking your eye, is the same. The distance this way is the same, so that it's not like this or like that. It's touching, and it's equal distant from the point at which it's in contact, okay? The other thing you want to do is you want to be sure that this is 45 degrees from this for a reason that makes absolutely no sense, but I'm going to explain it to you anyway.
So Rustin, you're still on the DLPFC?
We're on
You
DLPFC.
put the arrow horizontal as opposed to 45 degrees? Job rate puts.
45 degrees. That's what I just
arrow,
said.
I mean, the arrow is horizontal,
On the
basically, to the
coil.
ground. Yeah, the coil, the arrow on the coil, right? The big arrow.
What's the question?
Well, you have it sort of horizontal to the ground, parallel to the ground.
Right.
Some of the literature.
What's your alternative?
Job rate, yeah.
I told him it has to be pointing 45 degrees.
Go talk to him.
What? This is 45 degrees from here.
How do you measure the 45 degrees?
45 from what?
This is 90. This is 0.
Okay.
This is 45 degrees.
Can I
Now I'm going to
step
tell
in
you
here?
why, and
Can
it
I
makes
step
no
in for a
sense.
quick second here? I'm just going to ask, just for clarification, because Jabber, you're doing, this. I mean,
That's
a lot of
90.
places-
That's
No,
90.
I'm saying this arrow,
Right.
this arrow.
That's at 90 degrees.
How
To
is
what?
it 90?
So that's DMPFC.
Right, but 90 to what?
Midline. This is your midline. That's your reference
Oh,
point.
this is 90 to midline.
That's right.
Got it. So if
Now
you-
let's talk about why,
Yeah.
because it's kind of funny.
How is it 90?
90 to this line.
Okay, so let's 0, right?
Uh-huh.
45 degrees, 90 degrees, with relation to the midline. Okay? So we want 45 degrees.
Oh, I see. Yeah, I see what you're saying. You're
Now,
saying
why?
relation to
Why?
the ground.
Why? Why do they do this? So TMS originated, the use of TMS to treat depression originated not with psychiatrists, although Mark George had the idea of using the machine for treating depression. But the first people to have the machines at the NIH were the movement disorder group headed by Mark Hallett. And that's one of the reasons DLPFC was chosen. That's one of the reasons 10 hertz was chosen. And that's one of the reasons why it's done at 45 degrees. Why? Because the motor strip, so in pictures you see the motor strip looking like, like this, like a crown, right? But it doesn't actually go like this. It goes like this. See, it goes up and backwards, okay? And when you do motor cortex stimulation, there's evidence that the angle at which you approach the gyrus or the sulcus, if you think that's what's going on, is important. So they did 45 degrees. Then there was a study that actually showed that the angle of the coil affects the excitability of the motor cortex. And I can send you that article if you want to. It's very nice, it's very beautiful. I'm obsessed with parameter space. So how do you know where to put it? How do you know what frequency? So any information on that is very valuable to me. And it's very nice that they came out with that nice study. Now, they move it forwards and put it at the same angle and use the same motor threshold and pretend like that makes sense. It does not make sense. The motor cortex and DLPFC are completely different parts of the brain. I mean, when I say completely different, one of the ways that you can tell if something's different is that it's farther away. And when you look at the motor cortex and you look at the DLPFC, those are very far away. Now, any cortex that's next to another cortex is usually related in function and structure. So the cytoarchitecture is going to be somewhat similar. The response is going to be somewhat similar. This part of the brain gets its thalamic input from the lateral thalamic nuclei. This one from the mediodorsal nuclei. This is frontal lobe. This is prefrontal cortex. And there is not one shred of evidence that the fact that the motor threshold here gives you proof that neurons are firing means anything with regard to DLPFC. It means nothing. There's no evidence that says that you need 120% of what's here to go there. The 120%, like the 5 days a week, is based on the Eloise principle. Who knows the Eloise principle? Nobody knows the Eloise. Okay, so the Eloise principle is how the decision to do TMS 5 days a week was made. The news came to Mark George that the first TMS, randomized double-blind controlled study for TMS, was funded by the NIH, and he was so happy. He went home and told his wife, the first great government-funded study for TMS is going to start. We are funded for it. And she said, how many days a week? And he said, 7. And she said, so you have a machine that helps people with depression and ends our marriage? He said, 5. And that's called the Eloise principle. Now, that extends to many different aspects of TMS. Because parameter space is infinite, it's very hard to figure out what optimal parameter settings are. The idea that you have to have 120% of this to go here doesn't make sense. In fact, if you put it back here and you stimulate his occipital cortex, you turn it up high enough, he will have flashes of light, phosphenes. Does that have anything to do with this? No. Why aren't we looking at the sensory cortex? Because Mark Hallett was a movement disorder specialist when this was started. So motor cortex was interesting to him. And if you're a neurologist, you're going to do a lot of M1 stimulation. There are many conditions that respond to M1. If you're a psychiatrist, DLPFC is what you're going to do almost all the time.
So what intensity will you go up to?
Titrate to comfort. Because first of all, if the person's not comfortable, there's a high probability they won't come to session 2.
Yeah.
And I've had patients go to other doctors, and the other doctor said, now you're going to have to grit your teeth really hard. Your whole face is going to twitch. It has to be 120%. And the NeuroStar users, they thought that it was 5 centimeters anterior to the motor cortex,
Right.
which is not DLPFC at all, except in very, very tiny heads, of which you don't have one. Sorry. Hate to tell you. So 5 centimeters is here. They were stimulating frontal eye field, Brodmann's area 8, but it still works in a percentage of patients. Now, the DLPFC is what we stimulate, and let's say the motor threshold is 30, and this person is only comfortable up to 20. Try that a couple times. You'll see what happens. People get better with less than 120% of motor threshold. They do. And when you turn it up, they don't necessarily get better than they would have at a lower amount. We turn it up and we create twitching if and only if it's required and they're not having a result. And we're learning that earlier and earlier responses indicate whether or not they're having a result. Now, let's say the motor threshold is 30 and he can tolerate 50 and there's no twitching. And this happens.
So it's like 180%.
That's right. And what are we afraid of? What are we afraid of? Seizures. Do people have, try to look up frontal lobe seizures once. See what you find. There's almost nothing in there. This doesn't cause seizures. Stimulating DLPFC, except if you're a neurologist and you're taking a TMS course at Harvard,
So will you
it won't
basically
cause seizures.
tolerate discomfort? Like, what do you tolerate? Titrate?
We tolerate to efficacy, but we turn it up. We do tolerate some twitching if necessary, if it's not working without. But I'm not a twitch believer. As far as I'm concerned, pain and discomfort are not services I provide. I know in the LA area, there are specialized services where they'll come to your home and they'll create pain and suffering. Right?
We don't know these people.
But in San Diego, I just say, you know, these are services we don't provide. So 45 degrees, tangential, make sure the patient's comfortable. I have a motto that I love, I think other people should use too. It is, sir, is that touching but not pushing?
Yep.
I want this to be touching but not pushing. Do you feel it push on your head?
No, I do not. I
Good.
feel touch.
You want
Okay?
to draw on the shape of the coil.
Okay, so then the next thing you do is, after you've identified the location, and this is a really important moment, so you kind of have to, want to be sure that you're in the right place. You mark this. You can go all the way around. Actually, you can also go like this. But,
So that's very helpful, by the way.
so now when the technician comes, they put the hat on. They're very careful about putting the hat on. They line this up according to this. And to be honest, once technicians have done this for a long time, it becomes second nature. It's just not that difficult. So is that 1 centimeter difference there important? No. The magnetic field is a cloud, it's not a point. The DLPFC is an area, and it's not a point. True, the DLPFC is kind of 2 parts, but I don't know if you've noticed this, but that was where I said, and that's where it ended up being, right? So I'm anterior inferior to what the beam protocol said. And you can do that too. About a 1/2 centimeter anterior and inferior. You see, DLPFC has 2 parts. One of them's there and one of them's there. This one connects more to the posterior cingulate. This one connects more to anterior structures. It's the anterior inferior DLPFC that produces a better antidepressant response. Okay? The DLPFC is not one area, it's actually 2 areas. And if we have time, I can show you Broca's area is right here. And what you can actually do is you can actually create speech arrest. So I can ask him to start talking, I can do a continuous theta burst, I can put it in that area and he won't be able to talk.
Okay, can we please try? Come on, we just want to see.
And I have had spouses say, is this a commercially available device? I can get my spouse to stop talking? Yes. Yes, it's a commercially available device. Okay, so setting it in place, like I said, is it touching but not pushing is a really good thing.
They're very quiet.
Okay. So that's beam protocol. Should we quickly go through some other locations too, as long as you're interested? I can see you're fascinated and filled with curiosity. Okay, so the first thing that you think about when you're going to change protocols, if you're going to change protocols, is the right. Just like we stimulate the left, you can inhibit the right. 10 or 20 hertz stimulation here increases activity. 1 hertz stimulation here decreases activity. Now, the other locations that you can stimulate include this. We talked about the ACC, the anterior cingulate cortex, which is very important in monitoring and cognitive control. And it's also important in motivation, enthusiasm, and treating anhedonia. So if you measure from here, 25%, and again, somebody that argues that 30% is different than 25% is not looking at the real world, because
25% which direction? From the top?
25% of the distance from Nazian to Inian,
Okay.
and so it's basically half the way to the midpoint, okay? And it's in the midline. So you're talking about a structure that's very, 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 very easy to identify. And the coil placement, there are a bunch of different options for coil placement. We do the coil place, we do right from the side, like this. We do it right in the middle, right at DMPFC. It's called DMPFC because dorsomedial prefrontal cortex. And the previous acronym was ACDC for anterior cingulate deep coil. Believe it or not, this FDA cleared coil is the deepest coil on the market that's FDA cleared.
So we're putting him here because he's anhedonic right now?
If he's anhedonic, if he has not responded to this, many people do the standard treatment here and then theta burst here, or standard treatment here and then a theta burst 5 minutes here. It doesn't take that much and it can add a lot. Many people blossom when you stimulate. I don't mean that literally, but they like come alive and they start enjoying things and they reverse the depressive process. We usually do it from the other side, but options include you can do it a centimeter to one side of the midline or the other side of the midline. Some people think that the direction that you're angling it at will affect that. Like this is pointing more towards the left, that's pointing more towards the right. So there's some people that will stimulate this way more for lethargic and that way more for agitated. And maybe that's correct, I'm not sure. There's some people who say that how you place it is very important, like left, right versus coming from the back. We have not seen much of a difference with that. And that supports the idea that the magnetic field is a cloud, that the polarity of it is not as important as one would think. So now let's look at the newest and most exciting two locations. And they are the orbitofrontal cortex and the orbitofrontal cortex. So this is the first one that was described by Nauziel and his group in Europe somewhere, as if Europe were one place. Usually patients in the machine are more conveniently set up. I'm not sure why the angle's so hard. So what did I just do? So there is this location called F1 and F2. It's basically right above the right eye. It's a couple centimeters. It's basically halfway up. There are some measurements you can do, 10% this way, 5% this way. It might have been the other way around. But basically, it's from the side like this. Now, in my opinion, because I'm a neuroanatomy geek, the angle of this thing now is very important because the orbitofrontal cortex is sitting on the anterior fossa. It's like sitting like this, and you're trying to shoot it like this. Now, there's an argument about that too. Some people think that the frontal pole and the orbitofrontal cortex are the same thing. I don't. So I try to get this so that it's angling, so that it's headed directly. If you imagine the person's eyes, and then you go up, there's a little shelf right here. So you want it to be going towards that, and it can be straight from the front, or it can be a little bit from the side like this, because your orbitofrontal cortex goes around like this, okay? And sometimes it can be more comfortable or less comfortable depending on if it's more medial or more lateral. This stimulation can be done inhibitory, 1 hertz, or continuous theta burst, and it was described for obsessive compulsive disorder or TMS refractory depression. So Downers, Bloomberger's group, stimulated somebody here, it didn't work, stimulated somebody here and it didn't work, depression, 1 hertz right through there, right orbitofrontal cortex, you got better. And of course, if that happens with one person, we should all imitate that, right? But it does work. That's what that case report was for. Now, the other side is even more interesting. Left OFC. As we discussed, positive affect is related to left-sided activity. And the concept was that for addiction, the reward pathway has the left OFC as part of its circuit. So the left orbitofrontal cortex is projecting down to the ventral striatum, the nucleus accumbens, which is affected by addiction. So if you inhibit the left, the idea was, you can reduce addiction craving. And Colleen Hanlon and her group at the University of South Carolina have shown that you can achieve a 50% reduction in craving, alcohol and cocaine, in 5 days. And if you keep doing it, it keeps getting better. I'm not saying it's the answer to addiction, I'm saying it can be helpful for addiction. And just like it can be helpful for alcohol and cocaine, gambling addiction, sex addiction, video games addiction, some of these things do respond to left OFC stimulation. We do the exact same stimulation that Colleen Hanlon did, which is 2 minutes continuous, 1 minute pause, 2 minutes continuous. We do that for both of these, even though she developed it for the left, we also use it for the right instead of 1 hertz. It's very, very effective.
And you said at 1 hertz?
Either 1 hertz or continuous theta burst. I'm pretty sure Fred programmed it in there. I gave him detailed instructions, so it should be available on this machine. But if not, it's continuous theta burst for 2 minutes, pause 1 minute, and then continuous theta burst for another 2 minutes. Now, why did I go into all of that boring stuff about the fact that the motor threshold shouldn't be the be-all and end-all? Well, look. Let's say you're doing inhibitory stimulation, right? And the person's tolerating it fine, and you've got like 1 hertz stimulation on this side, or 1 hertz in the orbitofrontal cortex. Are you going to limit yourself to 120% of motor threshold? No. It's an inhibitory stimulation. It's not going to cause seizures. It's quieting the brain. You can turn it all the way up. And patients like it to be turned all the way up. It's 1 hertz, so it's click, click. And there's no reason to limit yourself at all. Same thing with continuous theta burst. Now, with excitatory stimulations, with 20 hertz, with 10 hertz, with intermittent theta burst, you don't want to just go hog wild, but even if you did, you'd be okay. But with inhibitory stimulation, you're completely okay. Now, what's the relevance of that for somebody who has a seizure disorder? Can you do TMS on somebody who has seizures? I hear many no's in your mind. I'm a psychiatrist, so I can read your mind. That's the party line. The truth is that TMS can be used to treat seizures. If you use a quieting, calming stimulation, you're not going to cause seizures. Just do it on the right. Go ahead and do it. They're not going to have a seizure.
So you can do 1 hertz inhibitory
On the right.
on the right for their depression.
Depression. So a study done by Fitzgerald and colleagues looked at right-sided 1 hertz, left-sided 10 hertz, and the combination of the two. Which would work better? And the intuitive thing is you add inhibitory and excitatory, that should be better. All 3 groups did exactly the same. 1 hertz on the right is absolutely as antidepressant as 10 hertz on the left and has a 0 rate of causing mania, reduces anxiety. Only downside is that the excitatory stimulation on the left has all kinds of cognitive working memory benefits, executive function benefits that the right-sided doesn't have. But when in doubt, you can just go slowly and start low. I had a gentleman who came to me from Arizona, and he had 2 faceplates right here in his cheeks, metal, and nobody would do TMS on him. So we started with it like this far away, and we crept down it very slowly, just doing pulses to see if he felt anything or if it got warm. We got closer, and we got closer, and we got closer, and we did it right here, and there's no problem. But do I want to do trains of 10 hertz or continuous theta burst for somebody with metal plates in his face? I could, because I went very slowly, and I made sure that he could tolerate it. But it's a lot of a better idea to do 1 hertz. 1 hertz isn't going to hurt anything, and it can do a lot of good on the right side. So you're absolutely, 1 hertz is just an amazing stimulation. I've seen people who 30 years of depression evaporates in 1 session and never comes back.
How about if someone's done tattoos on their eyes or their eyebrows?
This is irrelevant.
Okay. You can do
So
all of it?
almost all metal in the person's head, including dental fillings, is a far enough distance from the magnetic field. Remember that the strength of the magnetic field varies with the inverse square of the distance. So when you're here at 2, right, and then you go to 4, you're barely getting through the cortex. Nothing is going on in the cheeks and the mouth and the gum. And the idea that you can't do this with a cardiac pacemaker is ridiculous. Look at how far this is away. This is just ridiculous. And if you look at a BrainsWave device, the BrainsWave people will have you put up a sign on the door that has this big warning, radioactive material, important medical devices through this door. If you have a pacemaker, don't go through this door or you will die. I assure you, you're not going to die. And pacemaker is not going to be affected by TMS unless it slips and falls right over the guy's heart. And if that's happening, you've got bigger problems than taking the wrong patients, right? But really the distance of the magnetic field from all of these structures is so far that it's not really an issue. Does that make sense?
Coils and clips.
That's a little bit different. So if a person has aneurysm clips, in their middle cerebral artery, no, I'm not going to, if they're ferromagnetic, I'm not going to do that. There is one case report of a person who had deep brain stimulating, this horrible operation for Parkinson's where they put these stimulators and they stimulate the same stimulation in both subthalamic nuclei, which clearly indicates somebody didn't understand about the asymmetry, emotional asymmetry of the cortex, right? Because they're doing the same stimulation in both subthalamic nuclei. And then the person comes out of the operation, and of course, Parkinson's a very suggestible condition. And if you say, okay, hold your hand up and we'll look at the tremor in the operating room, and then you say, I'm turning it on, their tremor will stop before you turn it on, right? So it's very suggestible. But what's not suggestible is the profound deficit in executive function that these people have after the operation. Now, tremor is a little bit of shaking in your hand, and it can be a problem. Loss of executive function gets at your humanity. Anything that interferes with executive function should be taken very seriously. Granted, many of those people regain their executive function, but I think it's skating on very thin ice to take a person with Parkinson's disease and reduce their executive function, reduce their cortical activity and their DLPFC. But that's just personally what I think. And people confuse deep brain stimulators with deep TMS, and they're not the same thing, obviously. One of them involves blood on the carpet and everything. We don't do that. We do TMS, no blood on the carpet. Other questions? Oh, so we did orbitofrontal cortex on both sides. We did DMPFC, and like I said, locating any structure in the midline is a piece of cake because it's in the midline. You only have one dimension to deal with, right? And there's a bunch of structures. There's the DMPFC here. You go a little bit farther and you get the pre-SMA, the pre-supplementary motor area. Then next to that, you've got the SMA, the supplementary motor area. And these things can be useful in things like Tourette's, obsessive compulsive. It has to do with twitching and gating. And then here is your motor cortex. If you put it right in the middle there, you're usually affecting the motor cortex that innervates the legs. Right next to the legs is the genitals, but I dare you to try to get that. It doesn't get that deep or something. If you stimulate at the motor cortex in the area of the legs and the genitals, sometimes you get somebody bursting out into laughter, which is a lot of fun. So I encourage you to do that if you're a neurologist. If the patient has chronic pain and DLPFC didn't work, M1 might work. And then there's a location right here behind in the parietal lobe, the precuneus cortex. And in my experience, when you stimulate precuneus, and there are several reasons to do it, you can turn it up as high as it goes. It doesn't bother the person at all. One of the advantages of midline stimulations is they're very, very tolerable. And the precuneus stimulation like this is the most tolerable. Usually people can have it turned up all the way and they're fine. Whether or not it's effective. Precuneus has been associated in a Japanese study. The thicker it is, the happier the Japanese person is. A very large study that looked at this. And nobody really knows what the precuneus does, but there's reasons why it might be a good place to stimulate.
And where was the Tourette spot?
SMA. Now, the SMA is different on the left and the right. So my complaint about the deep brain stimulation devices, that they do the same on both sides, applies to this, but we don't know if we should be doing an inhibitory or excitatory on left or right, because we really don't understand the SMA as well as we understand some other things. The laterality of that difference in emotions is significant, because as you move towards the midline, it's a difference not in valence, not positive or negative, but as you move towards the midline, you have more and more structures that deal with self, like your muscles, your intentions, your free will. So SMA has been called the free will cortex. And because pre-SMA is right before it and can veto anything you're about to do, the pre-SMA can say, no, don't do that. It's called free won't. So there's free will and free won't, SMA and pre-SMA. And sometimes one is more beneficial for those and sometimes the other is, sometimes inhibitory, sometimes excitatory. I have not seen patterns. Another place you can stimulate in the event that it's necessary is for tinnitus and for auditory hallucinations. And what we're looking at is this right here. Now, this might be a good reason to get a neuronavigation device if you're not feeling comfortable with the location. But basically, above and behind the ear, about 2 centimeters. And you've got two structures that are right next to each other there. One's called the TPO, the temporoparieto-occipital junction. The other right next to it is the posterior superior temporal gyrus. And when you inhibit that, auditory hallucinations get better. There's another machine better than TMS, but TMS works fine. And the TPO is useful to stimulate in cases of Asperger's, autism. You want to do it a little bit higher. TPO is higher, but you want a little bit more parietal than temporo and occipital. And that works for that. Tinnitus also works in the same location as either one of them. You can do inhibitory. And you can try both sides, inhibitory and excitatory. So if a person has tinnitus on the left side, you can inhibit the left side. And if a person has tinnitus on the left side, you can excite the right side. So do the opposite stimulation on the other side in the event that the first one doesn't work. Questions about that? Other locations we stimulate.
So for autism, Asperger's, we use a similar approach. What's the
TPO.
rationale?
TPO. What's that?
What's the rationale for using that area? What's the reason?
So there's a field called theory of mind, the ability of one person to put themselves in another person's shoes to understand what the other person's intentions and awareness is. And that ability is located to the TPO and a little bit higher the parietal lobe in that area.
You increase empathy?
What's that?
You can increase empathy?
I think you can.
Perspective taking.
I think you can, yes. There are several different autism stimulations. It's almost a whole field in and of itself. There's a group in Kentucky, there's a group at Harvard, there's a group in Australia, and they all do different stimulations for autism.
Do you know a few others? A few of the other placements for autism?
Yes.
Do you know where they are?
Oh, are you quizzing me?
No,
Yes.
no,
Okay.
I'm not quizzing you,
So
just
the
asking you.
Louisville people with Casanova and everything, they do basically DMPFC, 1 hertz. And the protocol is very interesting, we'll talk about it, but it's once a week, 18 weeks, and that sort of thing. So 1 hertz stimulation is going to quiet things down, I would suppose, on the right. DLPFC can be done. Inferior parietal lobe can be done. And then the Southern California autism protocol, depending on who you ask, has to do with the enhancement of alpha activity in whatever place it's missing. And so EEG is done, and the alpha activity is paid attention to, and depending on where the activity is low, you can do a 10 hertz, 11 hertz, 12 hertz stimulation at that location according to your EEG. And
You're talking about functional EEG or
that's the only kind of EEG there is.
Well, no, I mean, I'm talking about where you have analysis as to the percentages of this wave and this, that, or the other.
Yeah, QEEG, you're right. Quantitative EEG, you're absolutely right.
Yeah.
So yeah, this is quantitative EEG, and there are things that graph it out. EEG is very interesting and useful, and I'm putting together a free software thing, so that if you buy an EEG system, you'll be able to just plug in this software and use it without going through the 3 years of nightmares that I did to get EEG analysis working. How many neurologists are here? So neurologists actually do a 2-year fellowship in they call it electrophysiology, part of which is EEG. Actually, Fred did. You were a movement disorder person, weren't you? Did you do a fellowship in electrophysiology?
Actually, Mark Hallett is a very good friend of mine.
Yes.
Because we were in
So you
Boston.
didn't have to.
I did not have to, because I trained and practiced in Boston, and long story short, it's a small community, but we all know each other.
Yeah.
And Mark Hallett was working with this thing way before anybody thought it was going to have any implications. He's a pioneer.
Late 80s.
Yeah.
Late 80s.
Is this software that you're developing, is that the same one that Dr. Murphy's using in San Diego? Is it similar to?
So it's in the same idea, right? His is off in a different direction and will cost you $75,000. And you're welcome to do that. It worked for his son. Yes, no. Yeah, I'm using the Cognionics now, which is a $15,000 wireless and dry EEG, and it works great. And all a psychiatrist needs is MATLAB, EEG Lab. MATLAB will cost you $100. EEG Lab is free. There's a couple plugins, and then there's a couple scripts from me. And then you're off and running. And EEG is going to be big in this for that reason, because of autism, but also to detect people who will fail TMS. There's a peak at 8 hertz in the alpha range, and if you've got that peak, that patient will not benefit from TMS. Now, from an ethical standpoint, it's a great thing to do an EEG and find that out so that the person doesn't spend $30,000 or $15,000 on TMS and drive his butt all the way over the place 5 times a week because of LOEs. But from a business standpoint, it's a really stupid thing to do because somebody's coming to you for TMS and you're telling them, oh, it's not going to work in advance. But you can do other things first. There's other parts of the brain you can stimulate. There's other frequencies you can stimulate. You can use theta burst. But if they have a peak at 8 hertz, 10 cycles per second on this side will not help them. And similarly, if they have a higher alpha frequency like 11, 12, a 10 hertz frequency will miss them. And it's good that theta burst is here because it'll work in either case. EEG is also useful for a couple other things. There's an analysis called microstate analysis, which is the new wave of EEG. It's these tenth of a second conformations of the brain, and there's 4 of them. And you can map these out and watch them change with symptoms, watch them change with treatment. Eventually we'll be able to do predictions on what will and what won't work. The other thing about EEG that's very, very powerful is frequency coupling. So theta burst is based on the idea that a 5 hertz wave can be like an envelope for 10 gamma waves. So there's reason to think that working memory works this way, that the 5 hertz waves is the idea of Apple, and then the round red, I can eat it, there's a core. Each one of those is a gamma wave synchronized with the theta wave and represent different aspects of the apple. That is, it's called the binding problem. And Liss and Bujaki and many other people say this has been solved. That's how working memory works. Well, that theta gamma coupling is one of several different kinds of frequency coupling. And we can see where and how these kind of frequency coupling can be off and how we can help people with them. The saying that David Marsden said was that neurons that fire together wire together. And that's pretty much true, except neurons that fire in rhythm with each other. So if one's going like this and the other's going, you hear how they're together even though they're not doing the same thing. So one of them is a harmonic or a multiple of the other. And this is how neuronal ensembles know who they're talking to and when. It's a very exciting future that we're about to embark on. For example, Salinas and his group in San Antonio have shown that if you stimulate DLPFC with different frequencies, functional connectivity to M1, BA25, different areas will exhibit different functional connectivity. So basically, a part of the brain can talk to another part of the brain in that frequency. And then when it switches to another frequency, it's talking to another part. Does that make sense? So that the same part of the brain can do multiple functions. We knew this, but the wiring remains the same. It's just that the software is changing. So if it wants to communicate this way, it uses this frequency, this way it uses that frequency. And this is being decoded now. And you can look up Salinas' paper and he shows 5 hertz, 10 hertz, and 20 hertz, and the functional connectivity changes with each one so that the brain is connecting in different ways. EEG is there any MRI researchers here? I should be careful what I say. But EEG is the future of is part of the future of image-guided TMS. And because EEG works on a time scale consistent with the brain, that is, the brain has changes that range between 1/50th of a second and 1/10th of a second, and EEG can capture that, where MRI is summarizing what happened in 2 seconds. Now in 2 seconds, you've got somewhere between 40 and 100 brain changes. So if you're going to average over a 2-second period, you're not operating on the time scale of the brain. Your spatial resolution is very good, but your temporal resolution is catastrophic. 2 seconds is a long time when you're talking about the brain.